Welcome. In this video, we'll refresh the knowledge on core mechanisms behind breathlessness and apply them to clinical thinking. What is dyspnea? It is a medical term for shortness of breath or breathlessness. It's actually a qualitatively distinct sensation of having to put more effort into breathing. Initial thoughts about dyspnea were that it originates from respiratory muscle effort. But since patients with paralyzed respiratory muscles still experience the sensation of breathlessness, this was explored further, leading to the discovery of distinct pathways mediating dyspnea, which are related to but not purely based on muscle effort. This is a complex pathway which we will not go into great detail but just have a brief overview. So for dyspnea, afferents originate from chemoreceptors and other receptors such as the stretch receptors, and these are transmitted to the brain. The central information processing involves the limbic system and the cortex. The efferent signals then reach the respiratory muscles. Imbalances related to any of these components give rise to breathlessness. Three main components contribute to dyspnea, that is, problems with efferent signals or problems related to central information processing. The central processing in the brain sort of compares the afferent signals to the efferent signals, and dyspnea results when there's a mismatch between the two, such as when there's a need for ventilation which is not met by physical demands. So basically, dyspnea results when there is a mismatch between ventilatory demands and the ability to respond to these demands. So in other words, dyspnea results when a mismatch occurs between the demands and the physical breathing effort. And this mismatch is sensed by the central nervous system as dyspnea. Now let's look at the individual causes contributing to this supply-demand mismatch. Firstly, the demand can go up with higher oxygen requirement states such as high altitude anemia or increased carbon dioxide production in severe infections or high metabolic states, and also in metabolic acidosis. So in these settings, ventilatory demands rise beyond what it's normally required, pushing beyond the baseline physiological status. So reduced capacity to meet demands can happen with pulmonary conditions, which might decrease the ability of the lungs for gas exchange and ventilation. So these can be conditions affecting the airways, lung parenchyma, vasculature pleura, or chest wall. And cardiac causes can be quite diverse, basically conditions involving any one of the following: myocardium, pericardium, valves, cardiac rhythm can impair the cardiac output, affecting the pulmonary circulation. In these settings, the body's ability to respond to normal physiological demands is compromised, resulting in breathlessness. So, do you experience dyspnea when exercising? Not really. During exercise, you breathe harder and faster to meet the increased metabolic demand. This is physiological and not as same as dyspnea. In healthy individuals, the effort to breathe is matched by the effect of breathing. Ventilation and gas exchange increases sufficiently to meet the body's needs. So if you approach your maximum respiratory capacity, you naturally reduce the intensity or stop so that the mismatch is avoided. In contrast, in a breathless patient, there's already a mismatch. The brain's drive to breathe is high, but ventilation or gas exchange does not improve enough. So they must breathe more and more to try to compensate, yet the effect lags behind. So this produces a distinct, uncomfortable sensation, dyspnea, which is associated with what we call respiratory distress. So now let's look at types of dyspnea. We'll particularly look at exertional dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. Exertional dyspnea occurs during physical activity. During exertion, oxygen consumption and carbon dioxide production increase, which raises the ventilatory demand. A healthy cardiopulmonary system can meet this demand, but if disease affects the heart or lungs, the system cannot respond adequately. For example, in heart failure, there's fluid congestion in the lungs, and in COPD, there's airflow limitation. Both of these reduce the ability to meet increased ventilatory needs, resulting in dyspnea. Orthopnea is shortness of breath that occurs when lying flat and improves on sitting up. When we lie flat, gravity no longer causes blood to pool in the legs, so venous return to the heart increases and preload rises. So in someone with left ventricular failure, the ventricle cannot handle this extra volume, and left-sided filling pressures climb and pulmonary hydrostatic pressure rises. Fluid then shifts from the capillaries into the interstitium and alveoli, causing pulmonary congestion and edema. This impaired gas exchange and produces intense breathlessness. So in the upright position, the venous return to the heart decreases, which reduces preload and pulmonary congestion. Standing or sitting also allows downward displacement of the abdominal contents and more efficient diaphragmatic movements, improving lung volume. As a result, symptoms ease. So patients with orthopnea are often relieved by sleeping propped up on pillows. Paroxysmal nocturnal dyspnea refers to sudden episodes of severe breathlessness that wake a patient from sleeping, usually 1 or 3 hours after lying down. And this improves when the person sits or stands. So classically what happens is the patient is sleeping comfortably and then the patient suddenly wakes up due to intense breathlessness and sits up. And after sitting up, the symptoms are relieved. This is often linked with heart failure and left ventricular dysfunction. When in lying down position, as discussed earlier, venous return to the heart increases and the preload rises. This will worsen pulmonary congestion in patients with underlying left ventricular dysfunction. During sleep, another key change in the body is that there is also reduced sympathetic support. This further reduces the cardiac contractility and the ability to compensate, which worsens congestion. So again, these patients, as mentioned before, they wake gasping for air, sometimes coughing or wheezing, and feel relief on sitting up because the upright posture reduces venous return and redistributes fluid away from the lungs, lowering the pulmonary pressures and improved ventilation and perfusion. So in a patient with heart failure, what is the order of development of the symptoms? Orthopnea, paroxysmal nocturnal dyspnea, and exertional dyspnea. Think about this and we will discuss further during the large class. Thank you.